Hey there, everyone. In every episode, we here at Healthcare Logic for Growth try to review at least one issue or problem that influences whether a healthcare or life science company can be successful or if they're positioning for failure. And we break it down into something you can act upon, right? You can plan around it. You can think about it critically and prioritize the next steps. Today's issue is no different. There is one thing though I want to tell everybody. The issue itself is enormous because it affects everybody. Now, we focus on small companies, healthcare companies, and startups, but it is a big issue. And it sits underneath almost every healthcare startup or emerging healthcare solution you've ever heard of, including the ones that ended quietly instead of successfully. In a word, reimbursement. The title of today's episode, Reimbursement, the Hidden Roadblock. One of the questions we want to answer is why can a product be clinically strong, incredibly well received, even market ready, and still struggle to generate real sustainable revenue? So let's get into it. So let's consider this. We at Life Science Logic have seen a pattern with a growing number of early stage healthcare, digital health, and medtech companies, others as well, other categories, but these will work for the purposes of today's discussion. They build the product first and treat reimbursement as a conversation for later. They're not the only ones. A lot of people do this in healthcare. And until they get acclimated to a variety of reimbursement functions and processes, it's an easy mistake to make. That's why we're having this episode today. Now, again, in some other industries, that process works for them. People want something shipped, whatever product or service they have to the people, then figure out billing afterwards. They just wanted a new customer, right? But that's not healthcare. In healthcare, that order and process can quietly sink your business. So, getting a new CPT code recognized, negotiating a value based contract, getting onto an employer's covered benefits list, none of these are quick administrative steps. They're long processes run by different committees with different evidence standards and different timelines. Take the AMA's own CPT process. Insiders who've taken codes through this process describe it as commonly taking years, not months. And I don't think they're exaggerating, especially once you factor in building specialty society support and generating the evidence the CPT editorial panel expects to see. So if you don't map that path early, you can end up with something very special, clinically credible, but commercially very hard to sell. That's the hidden risk we're unpacking today. Why reimbursement complexity is one of the biggest barriers to scaling healthcare innovation, and what a better sequence might look like if it makes sense to you. And to be clear, this isn't a niche problem for one type of company. Like I said early on, if you're in healthcare, you understand reimbursement or you become familiar with it as your company moves forward. It does show up for digital health platforms waiting on a coverage decision, for diagnostics waiting on a lab code, for device companies waiting on a bundled payment policy, for service-based models waiting on an employer to add them to a benefits plan. The point is, different technology, same underlying question. Who exactly is going to pay for this? And through what mechanism? In almost every healthcare company, especially newer companies, there are myths or misconceptions about what to do as it relates to moving things forward. And there are three assumptions we hear from founders and commercial teams almost every week, and all three are dangerous. Number one, if the product works, someone will eventually pay for it. Okay, that's one way to look at it. Number two, the clinical evidence will speak for itself. That's a dangerous one. Timing is an issue there. Number three, we'll figure out reimbursement once we have traction. None of these are how the healthcare payment process works. A payer, an employer, a health system finance team, they're not evaluating your product on clinical merit alone. They're asking, Who's the real buyer? Does a billing code already exist? If not, what's the path to get one? Is coverage even possible under current policy? And what about specific evidence that we need? Do they have it? Can they get it? These misconceptions can increase overall spend, slow the forecasted timeline, and of course, allow competitors to jump in and move forward ahead of you. Payers are managing costs more aggressively. Employers are pickier about what they'll cover, and value-based care adoption is still uneven across markets. A point that I want to make here is from Rock Health. Rock Health's most recent digital health funding data shows something that's pretty telling. Capital is concentrating in fewer, larger rounds. Mega deals absorb nearly half of all funding in the first half of 2026, despite representing a small share of total transactions. We talk about that specifically in last week's episode, so if that's of interest to you, check it out. It's important. But that kind of capital distribution usually rewards companies who've already, solved the commercialization and payment problem. They're aware, they're familiar, they're ready. They don't look at just the clinical considerations. They're looking at commercial and payment as well. There's also a founder speed problem later on top of this as well. Teams are under very real pressure to launch pilots, to raise a round, to show traction before the reimbursement model is fully worked out. That pressure creates a false sense of progress. A signed pilot with a friendly health system feels like validation. And they should feel validated. It's a good thing. Um, but a pilot is not a payment mechanism. I mean, I don't want to rain on anybody's parade. Getting that validation is necessary, but you have to have your payment mechanism in place. Plenty of well-liked pilots have quietly expired without ever converting them into a paid contract, simply because nobody on the team took ownership of the reimbursement question early enough. So let me share a scenario to help make this more concrete. Picture a founder, we'll call her Maya. She's built a remote monitoring platform for a high-profile chronic condition. The pilot is incredibly strong. The results are good. Our regional health system loves the tool. Patients really like it. Clinicians like it as well. All good things, right? But you see, Maya assumed the health system would just start paying for it once the pilot proved valuable. Instead, she runs into four roadblocks in the same month. All of them are important. Roadblock number one. The clinical team loves the tool, like I said, but procurement controls the contract. And procurement wants unit economics Maya hasn't modeled yet. Roadblock number two. Finance likes the pilot idea, but wants stronger proof of downstream cost savings before committing to a budget. Roadblock number three. What about the payer relationship they hoped would fund this? Well, it depends on the value-based arrangement, one that requires outcomes data that Maya can't produce for another, 2-3 quarters. Roadblock number four. There's no existing CPT code that cleanly describes what our platform does. So billing falls into a gray zone, and frankly, that makes everybody a little nervous. And by the way, none of this means Maya's product is bad, quite the opposite. She's gotten a great response, but that helps you understand how important the reimbursement process is. It means Maya built the clinical case before she built the commercial case. And now she's stuck in pilot purgatory, if you will. Again, it's liked, it's praised, it's referenced in every health system hallway conversation, and still not generating sustainable revenue. Consider that the new codes for remote monitoring and AI-enabled services do get added. The 2026 CPT code set alone included 288 new codes, with new categories actually created specifically to describe shorter duration remote monitoring services. It's a good thing. But that process runs on its own calendar, driven by specialty society input and panel review cycles, not a startup's fundraising timeline. Here's what makes it especially painful. Every one of those 4 roadblocks was knowable in advance. The procurement question could have been mapped in a month. The first month could have been mapped in the first month. The finance team's evidence requirements could have been asked for directly instead of guessed at. The value-based arrangements data requirements were published. It's a policy, so it's not a surprise. And the GPT gap could have been flagged the moment the product roadmap was set, giving Maya a year or more of runway to start building specialty society relationships instead of discovering the gap after the pilot ended. So all of these things are very important, right? And there's a response to all of them. So what's a good and bad response? What might that look like? Well, a bad response treats reimbursement as a downstream problem. That's just straightforward. That usually looks like building the product before thinking about billing, assuming coverage will follow good evidence automatically, relying on vague ROI claims instead of numbers a finance team can underwrite, waiting until after launch to think seriously about contracting or coding strategy. That approach is expensive in a specific way. It front loads spending on product sales and pilots before anyone discovers whether the payment model will hold up. There's a better response. What is that? Well, build the reimbursement strategy alongside the product strategy from day one. Strong teams map the reimbursement pathway early. They decide which payment model is most realistic for their specific buyer, and they test that assumption with real buyers before scaling headcount or just spending too much. They build evidence that matches what the actual decision maker needs to see, not just what looks good on a pitch deck. And they sequence commercialization around the path to payment, not just the path to launch. In practice, that means asking a short list of concrete questions early. Does this belong in CPT-based reimbursement? And by the way, I probably should have said it earlier, but I assumed everybody knew. CPT is an acronym for current procedural terminology, and everything in healthcare is aligned with CPT codes. That is the fundamental building block for all reimbursement. The next question, or is a value-based arrangement more realistic, given current payer appetite? Should employers be the first target instead of health systems? Is direct contracting the smarter and near-term move while a coding or coverage pathway develops? And critically, what specific evidence moves a named buyer from interested to signed? That probably makes sense to everybody. Here's a live example worth knowing about. CMS's newer value-based payment models, including recent ones aimed at outcomes-based reimbursement, are explicitly designed to move some of the digital health classic barriers to working with Medicare, paying for outcomes rather than a specific technology, allowing direct patient enrollment, that's huge, giving flexibility on copay structures. That's the kind of pathway that rewards teams who understood the reimbursement landscape early, and it was early enough that they could build toward it and around it, rather than discovering it after the product was already built. It's worth saying plainly, neither path is fast, neither path is free, but mapping a reimbursement pathway will take less real analytical work, and testing it with actual buyers takes real relationship building. But when you think about cost, even though it's not free, that cost is small compared to the cost of building an entire go-to-market motion around a payment assumption that turns out to be wrong. You build it, and they don't pay for it. Not good. The teams who get this right treat reimbursement mapping the same way they treat a clinical study, something you plan and resource deliberately, not something you hope resolves itself. Now, there are some practical elements that you might want to consider. I mean, when we work with teams on this type of problem, there are 6 things we suggest building into almost every engagement. It's up to them, but it's something that they can look at and see if it makes sense or they may have completed half of them, but they have half to go, whatever the case. But we want these 6 things to be considered. Number 1, reimbursement pathway mapping, identifying the most realistic route to payment, CPT coding, coverage policy pathway, uh, uh, value-based contract, employer benefits, or direct commercial sales. You'll also know as we go through these elements that they sound very similar. We do that intentionally. We'll hit some of these hot buttons in different ways 2 or 3 times during an episode because there's a lot of moving pieces. We don't want you to forget them, which you can write them down. You can play this episode over and over. You can come back to it later, but we will continue to reference them as we go because this is the way to get it done, right? As it relates to reimbursement. So, number 2, buyer and stakeholder mapping, clarifying who actually influences the decision. Because in healthcare, the user, the buyer, and the payer are frequently 3 different people, and their objectives may be different as well. I've been there. It's tough. 3, evidence planning, determining what proof the market genuinely needs: clinical outcomes, economic value, workflow efficiency, or utilization impact, or all of the above. Number 4, competitive and market context, looking at how comparable companies get paid today and where the reimbursement gaps and openings exist. 5, commercial sequencing, deciding what must happen first: pilot, evidence generation, contract negotiation, or coding strategy. Number 6, narrative alignment, making sure the company's external story matches its real reimbursement path, especially if that path is still evolving. It's also worth knowing this landscape keeps shifting on the employer side. Recently, employers face their steepest benefit cost increases in 15 years, and that pressure is opening real space for non-traditional benefit structures, including individual coverage health reimbursement arrangements, to gain traction as an alternative channel worth watching. So I'm going to give a quick self promo because this is where Life Science Logic fits into Maya's story and maybe even into yours. We help teams turn commercial complexity into something understandable and actionable, usually starting with research, market mapping, and competitive intelligence that surfaces the real barriers before a company overinvests in the wrong direction. So keep that in mind as we go forward. The GFS, instead of simply sharing data and insights and walking away, we always suggest an actionable go forward strategy, and you can determine if it has merit for you and your team. But as I always say, sometimes it's easier to edit than author. Again, if this is making sense to you, begin a concrete sequence you can start this week. A 6-step GFS is probably worth thinking about. Step number 1, inventory your current billing reality. Does a CPT code already exist for what you do? If yes, which one? And how is it currently reimbursed? If no, is there an adjacent code you could map to? Or are you looking at a multi-year category 3 or new code pathway? Write the honest answer down. Be honest with yourself before you write anything else. You need to know that. Plus, investors are going to ask, as are partners, as are your team members. These are things you need to know. Step number 2, map the real buyer chain. List every party who touches the decision: the clinical champion, procurement, finance, the payer, and if relevant, the employer benefits team. Note who can say yes and who can only say no. Most stalled deals stall with someone who is never in the room. So you see why that happens. Step number 3, if possible, get the evidence requirement in writing. Ask the buyer or ask finance what number or what study would make you move from pilot to contract. Ask the payer directly. What outcomes data does your coverage policy require? Is there anything that's missing? Try not to guess what good evidence means to someone else. Number 4, build the unit economics a finance team can underwrite. Let's face it, The finance guys and gals love economics and they understand how this part works. So that means a real cost per patient or cost per episode model. Do it. Not hard, just takes a little analytics. Don't go with the directional ROI slide. If you can't defend the number in a room with the CFO, it's possible you may not yet be quite ready. All right. Number 5, test the pathway with 3 or 4 real buyer conversations before you scale spend. Not just a survey, not a warm intro chat, an actual conversation about whether they would pay or not, through what mechanism, and what they'd like to see first. The best kind of insight are those customers that are going to actually buy your product. All right. Number 6, sequence your roadmap around the path to payment. Decide explicitly what must happen first: pilot, evidence generation, coding strategy, or contract negotiations. And build your hiring and spending plan around that order, not around your product roadmap alone. By the way, if you'd like to dig deeper on anything we've discussed today, because there's a lot of moving pieces, check out our show notes for additional references and sources, that kind of thing. Okay, that's it for today.